All right, my friends, thank you so much for joining us. We are here to have another conversation and get some more information about what's happening in and around our county, but also nationwide in regards to COVID-19. And so we're joined here again with Dr. Chad Vercio. Another familiar face you may see is Dr. Casey Graves, and we have several other physicians from around the nation that are joining us. I'm going to have Dr. Chad Vercio introduce himself and share a little bit about where he's at, and then we'll invite everyone else to introduce themselves as well.
Yeah, so I'm Chad Vercio. I'm internal medicine and pediatrics. I am at this point primarily pediatrics, but I've been very involved with our COVID efforts at our local hospital. So I've been, hearing all of the updates and everything. And just grateful to have some friends and their colleagues on here today. Hopefully we can share some good information with you.
Thanks, Chad. Let's go to Dr. Casey Graves.
Hi, I'm Casey Graves. I'm assistant professor of emergency medicine here at Loma and in the emergency department.
Thanks for being with us. And we'll go down to Dr. Walter Klein.
Hi, I'm Walter Klein. I'm a pulmonary and critical care attending at Riverside University Health System, which is an affiliate of Loma University.
Thanks for being with us. And Dr. Jennifer Hanson, tell us a little bit about where you're coming from.
Hi, I'm Jennifer Hanson. I'm a pulmonary critical care attending at a small hospital in Slidell, Louisiana. It's pretty close to New Orleans, so we've had a lot of cases of COVID-19 over the whole month of April.
We really appreciate you being here. And last but not least, Dr. Jillian Off.
I practice adult infectious disease at a large tertiary care hospital in Los Angeles, the Cedar-Sinai Medical Center.
Thank you so much. Really glad to have you here. All right, Dr. Vercio, why don't you lead us off as we begin the conversation here?
Sure. Just wanted to say, first off, none of us are speaking in any official capacity for our different institutions that we work with. That's probably important for us to acknowledge up front. But we all have invested a fair amount of energy and time into thinking about this, and really want to make sure that that people have the best understanding possible. This is a really confusing situation. Communication has varied over time on what the medical community is expecting or seeing and that kind of thing. And there's been a lot of misinformation, out there on social media. So if you do find this helpful, we ask that you share it with friends and family that this could help their understanding of the situation, so that we prevent some of that misinformation that's out there. I think the first thing to acknowledge about this is that all of us want to go back to normal. This has been really, really trying. It's been really long. Mine and Mike's kids like to play together, and we haven't been able to get our families together for a long time. And that's really, that's just one tiny aspect of how difficult this has been. Many people have lost jobs. And so because of all this, the tendency is to say, let's get back to normal as quickly as possible. And then we'll be tempted to believe things that would get us there that may not actually be true. And so we wanted to, kind of cover some common misperceptions that we see kind of people discussing and talking about. And probably the first one to start with is the misperception that, this virus it's just like the flu. And so there's, probably quite a few different ways that this is different from the flu. I wanted to turn to Dr. Jillian Off, since she's infectious disease, and see if she could, talk to us a little bit about how the spread of this is different from the flu.
Sure. So I think the first most important thing is that because it's a novel virus, we're still learning in real time about how similar or different this will end up being. Flu viruses are well known to us. They have a certain, predictability, seasonality, and I think their spread is pretty well defined. And we have also really important mitigation strategies in place with vaccines and interventions that that are tried and true and that we know work. And even despite that, influenza is formidable and is something that that we deal with in the ICUs as well as a severe disease. So I think the comparisons to influenza are probably, yeah, not very apt. And in the setting, I think we identified early on that there was sort of a bad combination with this virus, because there appears to be very efficient spread, and even droplet spread, which we know is very well described with this, is sort of a continuum in and of itself. And then when you compare that to a disease that by any measure is going to end up being more virulent and have a higher incident death rate than influenza, even pandemic influenza, that's a bad combination.
Yeah. And here is a graphic I put up something that can show you, a little bit about how flu and COVID differ in the infectivity. So flu in general infects about 1 to 1.5 people, or each person affects 1 to 1.5 other people, whereas COVID infects twice that. And when you multiply people infecting each other, that rapidly increases beyond what flu is. So that's hopefully a helpful graphic. You can find lots of other things like that. I was hoping that Dr. Hanson and Dr. Klein could speak to a little bit of the pathophysiology differences between COVID and the flu, because they're both respiratory viruses, but from what I've read and what we've been seeing, it seems like they're quite different.
Yeah, Chad, I think in my experience, one of the biggest things that has been troubling with SARS-CoV-2 is that not only is it a respiratory virus, but it also it has an effect on the heart. There's upwards of about 30% of the patients that we're taking care of will have some degree of heart failure related to the viral infection. And then on top of that, we're also seeing a lot of clotting disorders with this virus. And that includes blood clots in the lung called pulmonary embolism. We're seeing strokes in very young patients. And this is due to the damage from the virus affecting the lining of the blood vessels. And so in my mind, that's one of the very challenging aspects of treating this disease, is it's not just a respiratory illness, but it essentially can affect every organ in the body. On top of that, when you compare it to influenza, I think one of the big issues that we're seeing in our ICU is these patients take a long time to show any improvement whatsoever. During flu season, we certainly have a lot of patients that come in very sick from influenza, but they do also improve relatively quickly, oftentimes in under a week. I have multiple patients right now that I'm taking care of in the ICU that have been here for over 3 weeks and really haven't shown any signs of improvement thus far from the respiratory side. So I think, I don't know if Jennifer has, a different take on that, but those are some of the, major differences that I've noticed so far in caring for patients with COVID-19.
Yeah, I agree with what Dr. Klein said. We are seeing high rates of other organ involvement, and when they have a bad case of this COVID-19, it's almost like they go into an inflammatory kind of hyperimmune response that just perpetuates a lot of the organ failure. And to me, this is nothing like the flu. I have treated a lot of patients with the flu, but I've never seen anything like this virus. And also a lot of them are ending up on hemodialysis, and the dialysis can barely keep up with the amount of acid that's building up in their bloodstream. And like Dr. Klein said, they're spending weeks, like 3 to 4 weeks on ventilators. We haven't at our hospital been able to get them out to long-term hospitals so much because those hospitals are also really full in our area. So it's been a really interesting time. It's been a bad combination of different organ failures for a lot of our sickest patients.
Yeah. So, that maybe makes, some of the, hopefully it's helpful to people that, have been hearing that it's just like the flu. And in general, most people fortunately seem to do well that get infected, but there is, a not small number of people overall, because it infects so many more people, that our hospitals could, have easily been overburdened if we hadn't taken some of the measures that we took, weeks ago now. So that probably transitions us to the next point of, some of the measures that we've taken. We've shifted from the, typical public health strategy has been quarantining the sick. And so, and that goes back, very long time. But we're approaching this differently, where we actually are essentially, in the sense, quarantining people that are not sick. And so, I know one of the reasons for that is because people are able to shed this virus and share it, and then therefore affect other people during a period where they don't have any symptoms at all, or they may not even develop symptoms, which makes it really challenging when you have people that don't have any symptoms, but yet are sharing the virus. And so that's, one of the reasons that we've wanted to basically do a lot of this physical distancing. And so I'm going to show a graphic here that kind of illustrates that. So on the right-hand side, you'll see both seasonal flu and SARS from 2003. And SARS, you can see that they're viral shedding. So if you look at the top of each graph, there's a blue part of a line and a purple part. And the purple part, there's a divider in between, which is when they have symptom onset. So the purple part is where they're symptomatic, and if you look at SARS, they were shedding, which is kind of the curve, well after symptoms had developed. And if you look at flu, it's very shortly before symptoms develop that they're infectious. So that's maybe a day at the most. If you look at the potential models, which were based on a study that they did of 77 people, 44% of people were infecting somebody else while they were asymptomatic. Or sorry, let me rephrase that. 44% of people that got infected were infected by somebody that was asymptomatic. So you look at, they have a couple of different scenarios, but it may be that people peak, with their infectiousness right at symptom onset. It may be that people peak and are infectious entirely before symptom onset. Or scenario 3 is that they're infectious during really their incubation period and have a different curve to that. So that's one of the reasons why, this physical distancing has been so important, even though it's been so challenging for everybody. So I didn't know if anybody else had any thoughts on that. Jill, I didn't know if you wanted to add anything to that.
Yeah, I think the long incubation period and this shedding in either asymptomatic or probably most of whom are kind of pre-symptomatic patients has
Right.
been a huge challenge. There's this long lead time, which definitely informs public health decisions and actions, because sometimes, the experience in New Orleans, and certainly other places that have been heavily sort of hotspots, you're seeing the effects of an event a few weeks later, and then couple that with these really long protracted clinical courses, and the resources and demands can really build up. We've definitely seen that here on a scale that's really small, but we can imagine how that could be difficult.
Yeah. So one of the other things that is out there is that your immune system would drop significantly if you spend a lot of time indoors or doing the sheltering in place, and that's probably pretty unlikely. It's not likely that if you've been sheltering in place, for 2 months, that when you go out, you're going to suddenly get a bunch of diseases because you haven't been exposed to things. Your immune system hasn't been exposed to things. I actually wonder if Mike or Casey, if you wanted to kind of talk about some of the healthy things that we can do, while we are sheltering in place or physical distancing.
Yeah. I mean, there's a lot of indoor things that you can do. It kind of depends on where you're at. Obviously, in New York, you can't really get out and go running and physically distance very easily. But in these areas, we can get out in the hills and get away from other people. So continuing to exercise will definitely keep you healthy. And I think you could probably speak more to this as well, Chad, but the majority of your immune development, as far as being exposed to things and having a robust immune system, which people are referring to as more of a pediatric thing where you're developing as a young child. obviously you do gain immunity as you're going along in life, but being away from other people for a matter of weeks or months is not going to significantly change that.
Yeah. Okay. And probably getting some sunlight, like you said, exercise is really, really important, not just for your physical health, but for your mental health. I hadn't exercised for several days, and I did last night, and I felt dramatically better.
Yeah, definitely.
So, and then, of course, eating healthy, avoiding a lot of sugar and that kind of thing. All right, one of the other kind of things that's been out there in social media is kind of that we can't trust the statistics for deaths, and so really calling into question, the way that numbers have been calculated. And there's a lot of confusion about this, because originally models were kind of showing very, very high numbers of deaths, and then they came out and said, well, they're going to be a lot lower, and then now we're actually going past what those secondary models showed. And so I just kind of, there's even been discussion about physicians being, pressured to document COVID when it may not have been appropriate. And I just kind of wanted to see, I know from the level of calls that I'm involved with, that hasn't happened at RUHS, at least not any official way. But I was wondering if, you, Casey, or Walter, or Jennifer, or Jill have, experienced any of that at your institutions.
I haven't had any pressure to document COVID in any setting.
Oh, we haven't either, Chad. If anything, there are probably cases that we're missing because of the inaccuracy of the swabs, but in no way has anybody been pressuring us to document COVID-19 as a cause of death when it wasn't.
I'm also not seeing any of that. If anything, probably some patients that are testing negative when they really do have it.
Mm.
Yeah, certainly as we've learned about testing, we've had, the clinical experience has been further ahead, and we've had repeated negative testing that's been managed as if, and then subsequently confirmed on additional testing.
Yeah. And I think part of this goes back to the difference in pathophysiology. And, if somebody has COPD and then gets COVID, that could be potentially more severe than if they got, say, human metapneumovirus or some other virus, or if they have an MI or a heart attack, and that's triggered by COVID. People may not naturally think of a virus as causing a heart attack or kidney failure or, pulmonary embolus, blood clots to the lungs, strokes, and things like that. But really, it does seem like it's precipitating a lot of these other things that couldn't cause death. Wanted to talk just for a minute kind of about the modeling. I mentioned already, the initial models were quite high as far as the number of projected deaths, with 1 to 4 million potentially in the U.S. The Imperial College released, that they were estimating 2.2 million deaths, which obviously we're not seeing that degree of death. Fortunately, in my view, that's a lot because of the physical distancing that we put in place. And that was all, assuming that people didn't do that, or maybe didn't even do it effectively if we did do it. Fortunately, it does seem like we've been fairly successful in decreasing the spread. So I don't know if, Dr. Off, you want to talk a little bit, about what it's been like for LA, kind of looking at your curve, and maybe Jennifer, as being in New Orleans, in Louisiana, what it's like looking at your curve as well.
Yeah, I'm certainly interested to hear about Jennifer's experience. We were keeping a close eye on the models early on. I think the models for our experience with sort of seeing wide community spread was very close to the model's prediction, at least in timing. I think we started to see it just sort of before that. So I think early on things matched up actually quite well. And we had an anticipated surge in the middle of this past month, which was predicted, and which was definitely, I think, different than expected, because as the models were being adjusted, there was sort of this good news coming out of California that, maybe resources were not going to be overwhelmed, and ICU beds were not going to be needed in excess. And that was after these measures were being put in place as the models were being adjusted. So our experience so far has actually kind of, I think, mirrored what the models and adjusted models have reflected.
Yeah, go ahead.
So I can't speak about the curve as a whole for New Orleans because I haven't seen the latest data on that, but I can just speak about my experience. I think we peaked in terms of new cases of the virus somewhere around April 15th to 20th. And then we almost didn't want to believe that it was happening because we were so afraid that we would see another influx of patients. So we kind of kept things as they were, but it's definitely slowed way down, and still seeing that we are flattening the curve. So the social distancing that I mean, people in the South, they understand, and for the most part, I think people are really listening and staying at home, and just doing a lot more fishing instead of going out and doing social events. So I feel like it's definitely working where we are, at least up to now.
Yeah, it's been interesting for me to hear on our calls. We have a report daily of how many patients there are. And definitely about 2 weeks ago, we started to see an uptick in that, number of patients. And then it's been really kind of more of a plateau for the last probably, 10 days or so, and starting to maybe slowly come down. You can see kind of in this graph that I've shared, how the difference between peak and number of cases overwhelming to the healthcare system and the difference have occurred that's kind of more gradual. So that was one kind of slide that, obviously we're trying to accomplish that. I wanted to show one other one that can show how the measures that we're taking can make a difference. And so that is this slide, which is from our county public health office, and one of our physicians was very involved with putting this together. And you can see the different models. So the teal is kind of with no protective measures, and you could see for our county how dramatically and quickly that went up. And then one protective measure was the yellow, two protective measures, the dark blue, and then three protective measures, the orange. And you can see that, that early on, those all have a very, very close trajectory. And because of the long period of infectivity for people with COVID and the long time frame of incubation, or basically how long they go from being infected to having disease, it can be weeks before you see a difference in what that curve might look like. And so what may look like to people where we haven't been overwhelmed, maybe because we put things in place weeks and weeks ago that have prevented that from happening. And so instead of being on that teal kind of trajectory, we're really, locally, we're probably right at the blue to in between the orange and blue, fortunately. So hopefully that kind of helps people understand kind of how those curves can work a little bit. The different methods to decrease spread, masking. I think one of the misconceptions about that is that you're wearing masks, or like surgical masks or general face coverings to protect yourself. It's really to protect other people, that you're less likely to cough or sneeze and share that virus, or just breathe out that virus. So that's one of the big things for them. And then obviously we're doing physical distancing. I think we're being much more conscientious about cleaning things in our hospitals, and even keyboards, mouses and stuff like that, to prevent spread between staff. And then one of the big things that's really, really important is contact tracing, where basically public health is able to determine who has an infection, who doesn't, and then who has an infection, and then be able to trace down all of their contacts and monitor those people to make sure that they don't develop infections. And our public health services have been pretty limited in this country until this, and so they weren't really adequately prepared for a massive kind of pandemic, not of their own fault, but just because of funding. Hopefully that will change with time. And then of course, one of the other things to decrease spread is lockdown, like we've done. Wanted to recognize that this lockdown is really, really hard. And so Casey, I know you had some strong thoughts on that. I don't know if you mind sharing them. And Mike, of course, you could share that yours as well.
Yeah, no, I mean, we see this on a daily basis in the emergency department where we're not really allowing family members to be present if they screen positive for any of the symptoms of COVID. So people are there without their family members. And I know that is, at least here, is continuing up on the floors and in the units. So people that are sick are not having their family support system with them. I really appreciate what everybody has done. We've definitely seen that downtick in the number of non-emergent patients that are in the emergency department. And we all understand what's going on now as far as people losing their jobs and losing income. I think we're seeing that across the board. Even here in the medical community, people are losing income as well. But yeah, I know people out there losing their jobs completely. And as a bit of a caveat to that, I think across the nation, I saw some numbers where the number of heart attacks went down by 30%. We didn't fix heart attacks. So people are staying home for things that they should be in the emergency department for. So if you're having symptoms of chest pain or feel like you're having a stroke, definitely come in. We are here, and we have ways of keeping people safe that don't have COVID in the emergency department.
Yeah, and that's something that worries me as well, of kids not coming in for things that they should be coming into the pediatrician's office or being seen for. We have lots of different ways to make sure that we keep our families safe. We have video visits. We're willing to call people on the phone. We are actually seeing patients in cars if we need to, because they or their caregiver has symptoms. So, I mean, definitely I want to echo what you said. If you need healthcare, please get it.
Yeah, I'll jump into that, Chad. Just in my addition to my work at Crosswalk as a pastor, I'm a chaplain at the Loma Veterans Hospital, and the trauma is so widespread in terms of how it affects families. Right now, even if a patient is COVID negative, there's a restriction on how many family members can come in and be present when a loved one has passed away. I was actually on call last night. I called in this morning, and there was a death. Several family members came. We could only let 3 come in. They were just grief stricken. It's so hard to deal with this. And you think about the effect that's going to have on families that are coming out of this. It's really, disheartening. But also, I think just looking at the fact that in Southern California, we've been sheltering in place for 50 days now. I'm thinking about, when we can go back to normal, or people are saying, no, things are not that bad. Let's get back to normal. What are some of the concerns for that and recommendations for us? Yeah.
Yeah. So, that raises a really good question. I'll share another slide, which basically, I don't know what Louisiana's plan is, but I can speak a little bit to California's. And I think California's is pretty reasonable. One of the big things is that we need to have widespread testing that would allow the state to isolate people and people that have been exposed, and then also trace who they've come in contact with. And we've really, really dramatically increased our testing capacity over the last, 6 weeks. And we still have to do more to increase it. We're not, ready for massive testing at this point. I was just thinking today about next flu season. Fortunately, we've been lucky that the flu basically completely stopped when we went into, stay-at-home orders or shelter in place. And so we haven't had to deal with that. But next fall, when flu comes back, we're going to have to be able to, rapidly test people for this. And then also the big thing is that we have to be able to take care of the medically vulnerable older people who are at higher risk or have to isolate at home. We need the healthcare system to be able to handle a potential surge of patients, in addition to maintaining the normal services, normal preventive and other medical care. We need identification of, treatments. We have a lot better understanding of the disease, than we did probably 2 months ago, but there's still a lot more understanding to develop. And then we also need guidelines for businesses and schools, and that's challenging, man. My hat's off to public health. This is a really, really difficult situation to kind of figure out. And then also we need kind of a data tracking system that can allow for early warning if we're seeing an uptick in cases. So I don't know if anybody else wanted to kind of add their thoughts on that plan, and Jennifer can definitely comment on Louisiana and kind of, her thoughts on that.
Well, I think it's definitely going to need to be a graded response as far as coming back out of that. It's kind of like driving a stick shift car where you have to match the clutch and the gas to be able to see where you're at, because you don't want to bring things back off completely and then you have a spike that reaches or exceeds our capacity. Fortunately, with the measures that our state has put in place, we haven't reached that or actually gotten near it.
Yeah. There's, a number of things, good reasons to kind of slow things down. Those are some of the major things. One of the things that, probably has been most difficult, like we already addressed, is the lockdown. Just wanted to cover a couple of statistics on this. There's been a lot of comparison between countries, and we don't fully understand, all of the variables of why some countries are affected more than others. There may be some genetic aspects of this, but a lot of people have pointed to Sweden as a model that we should have used. I just want to point out that Sweden at this point has 263 deaths per million, which would be equivalent to 86 deaths in the US by this point. Norway, which has, neighboring country to Sweden, only has 39 deaths per million, which would be equivalent to 12,753 deaths in the US to this point. Dramatic difference between Norway and Sweden versus lockdown like Norway's done, where Sweden has not. Italy obviously hit this much earlier, and they had 467 deaths per million, which would be 153,000 deaths in the US. They're obviously later in the situation than we are. And then Spain has had 531 deaths per million, which would be 173,000 deaths in the US. And then probably one of the ones that's most analogous to us as far as when it really started to kind of become prevalent, but they waited to implement anything as far as lockdown or shelter in place, stay at home, as the UK. And they have 405 deaths per million, which would be the equivalent of 132,000 deaths in the US by this point. Some of our big states, California, York, obviously has been more affected than California, but they implemented measures to slow things down much earlier. And so we have about half the number of deaths or less than the UK does at this point because of those measures. So those are just some of the things on the lockdown aspect of things. So anybody else have any other kind of thoughts on that or other things to consider?
Yeah, I think everybody's hopeful that we can take, concerted steps moving forward and not have gone through all this effort to slip too far off course. I think everybody wants to move forward in a safe way.
Yeah, Chad, I just think we, need to follow those steps that you had mentioned previously and go as slow as possible here to make sure we do this safely and do it the right way.
Yeah, I wanted to show, Jennifer, I don't know if you have any thoughts, or Casey, on that. I just wanted to show, kind of end with one graphic, which shows kind of the potential for a second peak, much larger than the first if we kind of relax things too quickly or in too rapid of a fashion as far as each gradual step or each step. So anyways, I'll let Casey and Jennifer say anything that they have to kind of close things out.
Yeah, I think we're all hopeful that it continues to go down. I think we are all also a little bit fearful that it could come back, and I think it's the potential peak would come before we would have a viable vaccine, which again is why having those different gradations of social distancing and actually changing your R0 or RT, the amount of infectivity is important.
Here, I fully expect it to come back, and I'm kind of waiting for it. I'm a realist, and I just hope that our health system can keep up with the numbers of patients that are showing up, and we don't have situations where we have to refuse a ventilator to someone just because they're too old. That was my big fear. That would be kind of heartbreaking for me.
Right. Yeah. Yeah. That would be awful. I know a lot of thought has been put into the ethics of this, of dealing with the disaster, essentially a disaster situation. And it's just awful for us to think about. But one of the things that I, has been kind of, like you mentioned, Casey, the vaccine of there's no like vaccine in the near future. A lot of people have been saying, well, we should just aim to get to herd immunity as quickly as possible. And one of the things that kind of troubles me about that is that, in my view, and Jill, you can speak to this as well, but there's no guarantee that herd immunity exists with this, in that there's a number of cases that seem to have been reinfected, and so, yeah, there's no guarantee. Hopefully would, but there's no guarantee of that. So I don't know if you had any kind of thoughts on that, Jill.
Yeah, I think there's lots of debate right now about how immunity is established, how early on, how long lasting, and to what degree. So I don't think we can confidently say that we know how to effectively achieve herd immunity outside of a vaccine in this disease yet. I just don't think that we yet have that information. And a lot of that will depend on how much the virus itself changes over time, in addition to just the human genetic or immunology.
Right.
And I think if you were to say that you could actually reach herd immunity, I think you have to have somewhere around 70% of your population infected, which that's the point, not to reach that point. So.
Right. Yeah. So, all right. Well, any last thoughts? Otherwise, thank you so much for all of your time, and what you're doing to kind of treat patients, treat families, in a really, really difficult time where you're putting yourself at risk as well.
Yeah, just want to say thank you to everybody for joining us, for participating in this conversation, for sharing your wisdom, your insight, your experience. Really, really appreciate you, and just pray for blessings on you and your continued care of those in need. And thanks everybody for watching and for joining in.
Thank you guys.